Hello friends, this is Dr. Madhurima Ganguly, your Pediatrics faculty at Global Academy of Medical Education. Now today we are going to start a series that is known as Pediatric Marathon Series. And the main aim of this Pediatric Marathon Series is to complete the entire subject of pediatrics in a very short period of time. So in this marathon series, we have subdivided the entire subject into various subparts like pediatric rheumatology, pediatric cardiology, pediatric infectious diseases, etc. And we are going to read the most important points from each of these subtopics. We will discuss the previous year questions asked in NEETPG as well as in INICET, and also will be focusing on some one-liners which are frequently asked in Fmge exams. So this module is a very high yield for your upcoming Fmge examinations, INICET as well as NEET or NEXT. So since you know that we are coming across the new pattern of NEXT, where we are expected to have more integrated clinically oriented questions. So before solving that integrated clinical questions, we need to have a brief overview of the entire subject. So in this marathon series, we are also going to read about ways and tricks to approach such clinically oriented questions, and I'll add some extra age points because more focus in next is going to be on clinicals. Okay, so please watch this entire module. So in this module, Pediatric Marathon Series Part 1, we are going to start with our first topic, that is Pediatric Rheumatology. Okay. So in rheumatology, the thing that we are going to do is eye manifestations in pediatrics. Okay. So oil drop cataract is found in galactosemia. And let me tell you, in galactosemia, we also get sepsis with Escherichia coli. So another one-liner is E. coli sepsis. Christmas tree cataract is found in myotonic dystrophy. And remember, myotonic dystrophy is a trinucleotide repeat sequence disorder. Sunflower cataract is found in Wilson disease. And KF ring, also known as Kaiser-Fleischer ring, it is found in Wilson disease. Now let me tell you the concept regarding KF ring. So what is KF ring? It is nothing but the deposition of copper in the Descemet's membrane of cornea. Right? Deposition of copper in the Descemet's membrane of cornea is what we call as KF ring. And you can test for KF ring by slit lamp examination. Now, if you find KF ring in a child, it is mostly associated with neuro-Wilson, that is neurological manifestations of Wilson disease. A child coming to you with chorioathetoid movements and you're suspecting Wilson, then you must screen for or look for KF ring, because 90 to 95% cases where there are neurological manifestations of Wilson disease, we will have KF ring. Does that mean that a child with hepatomegaly or hepatic manifestation, cirrhosis, liver failure, will not have KF ring? The answer is yes. 30 to 35% cases of Wilson disease with hepatic manifestations also present with KF ring. If KF ring is not present, that is in 10 to 12% of the cases, then also diagnosis of Wilson disease is possible. That means what I mean to say is that if you get KF ring in your examination, it gives an additive value to the diagnosis of Wilson disease and more towards neuro-Wilson. But if you do not get KF ring, it means it can be still Wilson disease. It can be a normal patient, or it can be, normal or some other diagnosis, or it can be a patient of Wilson disease as well. Coming to uveitis. Now, whenever in pediatrics we talk about uveitis in pediatrics, we have a huge lot of differentials for it. but at least you should remember one thing, that is juvenile idiopathic arthritis. Now, why I am concerned about juvenile idiopathic arthritis? Because most common eye manifestation in GIA is uveitis. Now, again, GIA has got various subtypes. Oligo-articular GIA. Oligo means less than 4 joints. So, oligo-articular GIA will have asymptomatic uveitis. So, you can only detect it by screening. Whenever you get a child of GIA and you refer the child to ophthalmologist to see for uveitis, because in oligo-articular GIA, it may not be visible in the naked eye. You need a screening for that. Whereas in polyarticular GIA or in enthesitis related HIA, that is HLA-B27 associated GIA, there can be symptomatic uveitis. The child will complain of red eye, decreased vision, etc. Okay? And pan uveitis, that is anterior and posterior uveitis, you get in one condition that is known as sarcoidosis. So you get pan uveitis in case of sarcoidosis. Okay. So next we have a triad: cataract, sensory neural hearing loss, plus patent ductus arteriosus. So this triad is known as the triad of Gregg. So this is the triad of Gregg. And where do you get the triad of Gregg? That is the congenital rubella syndrome. Now, let me tell you, in congenital rubella syndrome, most common heart disease is definitely patent ductus arteriosus. But if you are not given patent ductus arteriosus in the question, what will be the second best? The answer will be pulmonary stenosis. So, always PDA is important. PDA more common than pulmonary stenosis. Next, salt and pepper fundus. Salt and pepper fundus is again a feature of congenital rubella syndrome. Right? Coming to optic atrophy. Optic atrophy you get in various conditions, but for pediatrics point of view, we'll remember optic atrophy is found in white matter neuroregression. So, any diseases where there is white matter neuroregression, there is a chance of getting optic atrophy. Like gray matter neuroregression will get retinal degeneration or problems with the retina, whereas problems with the optic atrophy or optic nerve will get in white matter disorders. So, this is in white matter neurodegeneration. Next, coming to retinitis pigmentosa. Retinitis pigmentosa, what will be the presentation? There is going to be a painless, progressive loss of vision in the child. Retinitis pigmentosa has got a vast number of causes which you must be reading in your ophthalmology class. But I would like to mention at least 3 causes for retinitis pigmentosa, important from pediatrics point of view and medicine point of view, and which are frequently asked in your exams. Number 1 is the mitochondrial disorders, Kearns-Sayre syndrome. So, Kearns-Sayre disease is a mitochondrial disease which affects the heart and will also get retinitis pigmentosa. Okay. Next, we'll have Usher syndrome. What happens in Usher syndrome? We'll have retinitis pigmentosa and sensory neural hearing loss. So, I already talked about sensory neural hearing loss in congenital rubella syndrome. This is the second time I'm talking about not congenital rubella syndrome. I'm talking about sensory neural hearing loss with retinitis pigmentosa, that is Usher syndrome. And next is a paroxysmal defect that is known as Refsum disease. So this is again frequently asked, that is Refsum disease presents with retinitis pigmentosa. Coming to the next one, that is non-purulent conjunctivitis. So you get conjunctivitis, but there is no discharge. Usually in conjunctivitis, you get a red eye and there is watering. But if there is no discharge and there is a red eye, and I can also add another line that it is limbal sparing. Limbal sparing. Yes, you're right. We are dealing with nothing but the Kawasaki disease. Next is ectopia lentis, that means subluxation of the lens. It is found in two conditions. Number one is the Marfan syndrome, and number two is the homocystinuria. In Marfan syndrome, we are going to get a superotemporal dislocation of the lens. So inferonasal displacement we find in case of homocystinuria because of cystathione beta synthase defect. Now let me tell you, in Marfan syndrome it is basically because of fibrillin 1 gene defect. And you know that it is a tall stature, a child with tall stature, long slender fingers, arachnodactyly, okay, abnormal long bones are there, as well as there is a chance of affecting the aortic root. So we are going to get aortic root dilatation or aortic dissection or aortic rupture and even aortic aneurysm. And what criteria do we use in case of Marfan syndrome? We use the modified Ghent criteria. Okay. Whereas in homocystinuria, we are going to get that it is a cystathione beta synthase defect. The child will have a Marfanoid habitus, but there is an increased chance of thromboembolism. Okay. So a child with Marfanoid habitus plus increased chance of thromboembolism, that is stroke, will get in homocystinuria. Okay. So in homocystinuria, we'll have an inferonasal dislocation of the lens, whereas in Marfan syndrome, we'll have the superotemporal dislocation of the lens. So hopefully you have understood all these eye manifestations. Coming to Lish nodules. So this is nothing but Irish hamartomas, which you get in case of neurofibromatosis type 1, right? And you at least need to have 2 for diagnosis of neurofibromatosis type 1. Lens opacity or lenticular opacity is found in Down syndrome, that is trisomy 21. Next is Edward syndrome, trisomy 18, and Patau syndrome, trisomy 13. Brushfield spot is again found in Down syndrome. Now, can you tell me where do you get the Roth spot? Roth spot. Roth spot in retina is suggestive of infective endocarditis. Limbal corneal vascularization is a feature of riboflavin deficiency. Riboflavin is vitamin B2, whereas interstitial keratitis you can get in B2 deficiency or in herpes simplex virus infection or in late congenital syphilis? Since I use the term late congenital syphilis, let me tell you, we have the Hutchinson's triad for late congenital syphilis. What is the Hutchinson's triad? That includes interstitial keratitis, Hutchinson's tooth, and number 3 is eighth nerve deafness. So just remember the Gandhiji's word, I'll hear nothing bad, I'll not see anything bad, and I'll not speak anything bad. So involving all the ears, the eyes, and the tooth. Interstitial keratitis, Hutchinson's tooth, and the eighth nerve deafness. This triad is known as Hutchinson's triad, and it is a feature of late congenital syphilis. If I ask you one question, what is the earliest manifestation of congenital syphilis? The answer will be snuffles. The answer will be snuffles. Okay? Now, some other things that we need to remember from eye manifestations. Okay? Already we know if we use steroids in a child, it leads to immunosuppression, and also we need to monitor for glaucoma and cataract, right? So giving steroids in a child, we need to go for ophthalmological monitoring, like for example a nephrotic syndrome child, say who is on prolonged course of steroids, like in frequently relapsing nephrotic syndrome. Then what we need to do, we need to go for a periodic ophthalmological monitoring. Next, hydroxychloroquine. It's a drug which is used in SLE. It leads to bull's eye maculopathy. Another one-liner you should know, most common cause of vitreous hemorrhage in a child is trauma. So most common cause of vitreous hemorrhage in a child is trauma. Few points on leukocoria. So what is leukocoria? Is nothing but the white eye reflex. So leukocoria or white eye reflex is found in numerous conditions. You must be reading in ophthalmology, congenital cataract, retinoblastoma, PHPV, toxocariasis, even ROP, etc. I would like to make you understand the most common cause of leukocoria. The most common cause is congenital cataract. And you should know few points regarding retinoblastoma. So we already know retinoblastoma is the most common primary ocular malignancy in children. Can you tell me the gene? It is the RB gene, chromosome 13q14. Very important because it is a tumor suppressor gene. So what does tumor suppressor gene do? It follows the Knutson's two-hit hypothesis. That means two alleles must be defective, then only the disease will manifest. First, there is a mutation, that is a germline mutation which occurs in utero, and the next mutation occurs after subsequent exposure to the environment. Okay? And when these two alleles are defective, it produces the manifestations of the disease, that is retinoblastoma. You should know the most common clinical manifestation of retinoblastoma. So most common manifestation, answer will be leukocoria. If leukocoria is not given in the option, the next best will be strabismus or squint. Remember, the origin of retinoblastoma is the cells of the primitive neurosensory retina. And in retinoblastoma, what happens? If you're getting retinoblastoma, you should always look for other tumors. So, what bone tumor you should look? Osteosarcoma. So, if you're getting retinoblastoma in a child, you should always look for the second malignancy being osteosarcoma. Right? Now, few points regarding retinopathy of prematurity. When would you screen for retinopathy of prematurity, that is ROP? Less than 34 weeks or less than 2000 grams. It can be either or. This is the gestation age, this is the birth weight. Or if various conditions which are suggestive of an unstable course in the neonatal intensive care, or if the child, if the baby, not the child, if the baby has certain high risk factors, oxygen therapy, prolonged oxygen therapy, mechanical ventilation, blood transfusion, neonatal sepsis, intraventricular hemorrhage, apnea, poor post-neonatal weight gain. So all these are suggestive of stress factors, and in these babies you need to screen for ROP. When do we do screening for ROP? Usually 4 weeks. And in extreme preterm, that is less than 28 weeks or less than 1200 grams, usually we do it after an interval of 3 weeks. Okay? So this is the RBSK guidelines regarding retinopathy of prematurity. Next, we should also know bitemporal hemianopia. So it is nothing but a visual field defect, and it is found in optic chiasmal defect. Because of a tumor craniopharyngioma. Optic chiasmal defect craniopharyngioma produces bitemporal hemianopia. Two more. Pie in the sky. Visual field defect. That means nothing. It is the contralateral superior quadrantonopia. It's like this. Okay. This is gone. So this is known as pie in the sky. It is because of temporal lobe and the fibers being known as the Mayer's loop. Mayer's loop. Visible? Pie in the sky, temporal lobe, Mayer's loop. Similarly, pie in the floor. It is basically parietal lobe and Baum's loop. I would like to complete this eye manifestations in pediatrics with another one-liner, that is the convergence retraction nystagmus. You get the convergence retraction nystagmus in a disorder which is known as Parinod syndrome. You know what happens in Parinod syndrome? There is an upward gaze palsy. So you get the nystagmus while you're trying to converge the eye and you go for retraction. Suppose I bring my pencil here. So there is going to be convergence and retraction. So during convergence and retraction, we'll have a nystagmus that is known as convergence retraction nystagmus. So this is in short the eye manifestations in pediatrics. Very, very important table. Now, coming to this IBQ, which is my very personal favorite, first look at the eye. So, again, I discussed this. This is a non purulent conjunctivitis without any discharge and sparing the limbus. So, this is conjunctivitis, but there is no discharge. Now, before I already told you that non-purulent conjunctivitis you are going to get in a disease which is known as the Kawasaki disease. Now, let me tell you, in Kawasaki disease is never possible without fever. So, you should always have fever in Kawasaki disease. It's the sine qua non of Kawasaki disease. Apart from fever, you are going to have the cream criteria. So, I already talked about the C of cream criteria, that is conjunctivitis without discharge. C. Next, coming to R, that is the rash. This rash can occur anywhere in the body, but there is a predilection of this rash in the trunk. So CR. Coming to E. E is this erythema and edema of the hand and the feet. In the initial stage, that is the acute phase, we'll have erythema and edema of hand and feet. But in the later half, what we are going to have this, that is desquamation of the fingers of the toes. So we can have perioral desquamation, periangular desquamation, and of course perianal desquamation, right? So desquamation, it is a late feature. Remember this, desquamation is a late feature. CRE gone. Next comes to this, see this lymph node over here. So this is a unilateral cervical lymphadenopathy, more than 1.5 centimeter. Since we are living in a very endemic country like India, it is very important for you to remember that if you are getting bilateral cervical lymphadenopathy with fever, we should always rule out the master of all diseases, that is tuberculosis. But unilateral cervical lymphadenopathy more than 1.5 centimeter, feature of Kawasaki disease. So A gone, adenopathy. And lastly, the mucosal change, that is the strawberry tongue. So this is nothing but the mucosal changes. And here you can see the strawberry tongue. Can you tell me another condition where you get strawberry tongue apart from Kawasaki disease? Yes, it is nothing but the scarlet fever. So we have the fever plus cream criteria, and that makes our diagnosis as the Kawasaki disease. This disease is named after Tomishaku Kawasaki. And remember two one-liners from Kawasaki disease. It is the most common cause of vasculitis in India. Most common cause of vasculitis in hospitalized children. Majority are less than 5 years of age. It is the second most common cause of vasculitis in the world. Second only to Henoch-Schönlein purpura. सो वर्ल्ड में देखा जाए तो पहला है हिनॉक्स-शॉर्लेन पर्प्यूरा, उसके बाद कावासाकी डिजीज. इंडिया में ऑलवेज कावासाकी डिजीज स्टैंड्स फर्स्ट. Kawasaki disease is vasculitis. What type of vasculitis? Which vessel is affected? It is medium vessel vasculitis. Medium vessel vasculitis. So can you tell me another cause of medium vessel vasculitis? It is polyarteritis nodosa. So polyarteritis nodosa also presents with medium vessel vasculitis. Is it clear? And remember, this is a very important image based question And you get this image based question almost every year in INICET, even in next exam, NEET exams as well. So I can hope you are going to get this scenario. A 5-year-old child presents with persistent fever, not remitting with antibiotics, with right lymph node enlarged, edema of hand and feet, and there is irritability out of proportion with rash and mucosal changes with strawberry tongue. What is your diagnosis? The answer is Kawasaki. Which vasculitis are you thinking? Medium vessel vasculitis. Okay. So we'll just fill this. Classic Kawasaki disease, also known as complete Kawasaki disease, right? So it is the fever plus 4 or 5 out of the 5 cream criteria. What other findings that you get but not associated with the criteria? One is irritability. The child will be very irritable, out of proportion. We can also get BCG scar reactivation. If a child with Kawasaki disease complains of pain abdomen, you just palpate and you can get a palpable gallbladder. You can then advise for USG whole abdomen, because you can also find hydrops gallbladder. And there is a specific nail change that is known as the Bewes lines. And we can also get aseptic meningitis and aseptic arthritis. This too, statement, it is a statement based question in 2021 November INICET. Aseptic meningitis and aseptic arthritis is found in classic Kawasaki disease. Incomplete Kawasaki disease, it is fever plus 2 or 3 of 5 cream criteria. And remember, incomplete Kawasaki disease is more found in case of infants. Atypical Kawasaki disease means atypical organ involvement. What atypical organ involvement are we talking about? It can be hepatobiliary involvement or renal involvement or pulmonary involvement. Okay. Now, whenever you diagnose a child with Kawasaki disease, remember we need to do one investigation that is known as echocardiography, because we are very frightened about coronary artery aneurysm, right? So, whenever the child presents to me, I advise for an echocardiography, and the cardiologist sees the coronaries and about the coronary dilation, right? So, when will you advise for echo? That is when you should get an echo done in a Kawasaki disease patient. Remember, at the time of diagnosis. At the time of diagnosis or at the time of presentation. So that is in 0. So you should always do echo to be done at diagnosis. 0 means at diagnosis. Next, remember 2 weeks and 6 weeks. Why 2 weeks? Because in the first week of disease with Kawasaki disease, there is usually the coronaries are not dilated. Majority of the events in Kawasaki disease occur in the second week. Platelet count rises in the second week. In the second week onwards, late phase of second week, you will have desquamation, and you also have the coronaries being affected in the later part of the second week. That is why we do the echo in the second week and then we follow up at 6 weeks. Suppose at diagnosis we do an echo and there is no cardiac lesion, then we'll call it as uncomplicated patients. So in uncomplicated patients, we do the echo at 0, next at 2 weeks, and then 6 weeks after treatment. If the child is having coronary abnormalities, this is only for INICET, you should remember. Having coronary abnormalities, then you should do it twice per week. Week में 2 बार करना है. Still stabilization to look for thrombus. So you do 0 2 weeks, 6 weeks, and then 3 months, 6, 12. 3 months, 6 months, 12 months. 0 to 6 in all children. If the child is having complications, additionally 3 months, 6 months, 12 months. Why I am telling this? You need the echo as I told you because there's a chance of coronary dilatation and coronary artery aneurysms. And second is that you start the child on aspirin. Okay, and if the child is having giant coronary artery aneurysm, it may be needed that you need to start the child on warfarin as well. So if you're giving warfarin and aspirin, you need to monitor the INR. Okay, and INR should be between 2 to 3. So that is why we need to do echocardiography on every visit of the child. So this is a very, very important child. So what investigation or what is the most important investigation in Kawasaki disease? The answer will be echocardiography. And when you should do echocardiography, the answer will be at diagnosis. When will you do a repeat echocardiography? 2 weeks. Further 6 weeks after treatment. Understood? So some important one-liners. Most common manifestation of Kawasaki disease is fever. I already told you that Kawasaki disease is never possible if you are not having fever. What is the most common late clinical manifestation of Kawasaki disease? The answer is desquamation. And the least common manifestation of Kawasaki disease is cervical lymphadenopathy. Already I told this statement, this was asked in INICET previously. Aseptic arthritis and meningitis can be seen. And desquamation thrombocytosis occurs in the subacute phase. Now please remember, if I ask you, what is the status of platelet in Kawasaki disease? Platelet can be normal or it can be increased. So platelet count can be normal or increased. Usually it is normal in the first week and it increases from the second week onwards. Now, if in a child, if you are finding there is cytopenias, you are expecting the ESR to be high, the CRP to be high, and the platelet to be high, but instead you are getting a low ESR, low platelet, are you doing a wrong diagnosis? Possibly. Or you can do it, or you might be dealing with two more conditions. One is macrophage activation syndrome, HLH, or you might be dealing with MISC with KD phenotype. Okay. So most common CVS complication of KD is myocarditis. Kawasaki disease affects heart, but इसका मतलब ये नहीं है कि सिर्फ coronary को ही affect करते हैं. So most common CVS complication of Kawasaki disease is myocarditis. Also, we can have pericardial effusion, the water bottle shaped heart, or we can have some valvular regurgitation like mitral regurgitation. And sometimes KD can be so life-threatening, there can be shock, cytokine storm. The child can land up in PICU. We call it KD shock syndrome. So what is the most dangerous complication, or rather I should put it like this, most common cause of death in KD is coronary artery aneurysm. Again, one step ahead, thrombosis of coronary artery aneurysm. If thrombosis is not given in the question, suppose you are marking thrombosis of coronary artery aneurysm, it is not given in the question, then the next best answer is rupture of coronary artery aneurysm. So most common cause of death in KD is thrombosis of coronary artery aneurysm. It's more important than rupture of coronary artery aneurysm. Clear? So what is the drug of choice in Kawasaki disease? I always teach my students that whenever any question comes in Kawasaki disease, that is drug of choice in classic Kawasaki disease, in incomplete Kawasaki disease, atypical Kawasaki disease, IVIG resistant Kawasaki disease, always the choice is going to be intravenous immunoglobulin. And the dose is 2 gram per kg. And you should give it within 10 days of disease fever onset. Remember, there is no role of steroids. I mean, there are role of steroids in IVIG resistant KD, but steroids never are drug of choice. You need to give IVIG. So whenever whatever be the options, please choose IVIG, IVIG, and IVIG. Aspirin, salicylates. You give 30 to 50 milligram per kg of aspirin till the child is afebrile for 48 hours. And once the child is afebrile for 48 hours, you are going to start with 3 to 5 milligram per kg of aspirin for 6 weeks. So this high dose which you give initially, it is basically anti-inflammatory. And later on, that the dose of aspirin that you give is antiplatelet. So I told you in 6 weeks we do a repeat echo, and if there is no cardiac sequelae, we stop aspirin. If there is cardiac sequelae, we continue aspirin. And if there is giant coronary artery aneurysm, we not only give aspirin, we add warfarin along with it, and we try to keep the INR between 2 to 3. What is IVIG resistant KD? It means persistence of fever and symptoms 36 hours even after completion of infusion of IVIG. This is a very, very important statement. That is, the timeline is 36 hours. And it is completion of infusion of IVIG. So persistence of fever 36 hours even after completion of infusion of IVIG is what we call as IVIG resistant KD. Okay, so what do you do in case of IVIG resistant KD? What is the next best step? Treatment, repeat dose of IVIG. Already I told you कि कुछ भी क्वेश्चन में हो आंसर IVIG ही होना है, तो that is also is not doing any help. Then you go for IVIG plus methylprednisolone steroids. Again, that is also not helping. Next, you go for biologics, anti-TNF alpha inhibitors or anakinra, etc. So is the treatment portion clear? Let us see this diagram. So we find some lesions in the MCP, PIP and the DIP. These are the papular lesions. Can you see this? This papular lesions. So this is nothing but Gottron's papules. And you get this Gottron's papules in a condition that is known as juvenile dermatomyositis. So let us see another picture. Always what I advise is, if you do not know something, please break the word. Juvenile, that means juvenile period, children. Dermatomyositis, that is, there is dermatological manifestations and myositis. So what dermatological manifestations are we talking about? It can be this Gottron's papules. It can be a photosensitive rash, that is rash in the photosensitive parts of the body. Or it can be a malar rash. Now malar rash, if it spares the nasolabial fold, then it is acily. But if it doesn't spare the nasolabial fold, it can be any other condition. So, photosensitive rash, malar rash, Gottron's papules. Next is mechanic hands. So, what is mechanic hands? It is nothing but scaly plucks along the flexor tendons. So, scaly plucks along the flexor tendons is what we know as mechanic hands. And remember, mechanic hands is associated with anti-Jo1 antibody. This came in Fmge. Anti-Jo1 antibody is associated with. The answer will be juvenile idiopathic arthritis. No, the answer will be juvenile dermatomyositis. Very, very important. So, anti-J1 antibody means JDM, juvenile dermatomyositis, and anti-J1 antibody, if you are more specific, asked much more, then the answer will be mechanic hands, right? So, if you're giving this image is a personal favorite of INICET. Okay, every year they give this and frame some new questions. Like 1 year they gave this image and asked, "What is the diagnosis?" The answer is juvenile dermatomyositis. Then, what is the lesion? The answer is Gottron's papules. Next, how do you manage this? The answer will be steroids. Understood? And let us see another image, which is again a favorite of INICET. This is a rash around the eyes, and it is erythematous. This is known as heliotrope rash. So, heliotrope rash with Gottron's papules. Heliotrope rash with Gottron's papules is what you can get in something which is known as juvenile dermatomyositis. So, we understood the dermatological manifestations of juvenile dermatomyositis. Now, already I told anti-Jo1 antibody associated with mechanic hands and JDM. Let me tell anti-MDA5 is associated with interstitial lung disease in case of juvenile dermatomyositis. Okay, so you should remember two antibodies: anti-Jo1 antibody that is associated with mechanic hands, JDM, and anti-MDA5 interstitial lung disease in JDM. So let us read the diagnostic criteria of JDM. So there is a rash plus any 3 out of the 4. Proximal symmetric weakness. I was telling you myositis. Basically, JDM is the most common inflammatory myositis in children. So there is a proximal myopathy. So can you tell me the symptoms of proximal myopathy? There is going to be difficulty in climbing upstairs. There is going to be difficulty in combing hair. There is difficulty in standing from sitting position. So all these are manifestations of proximal symmetric weaknest. And there will be enzyme elevation. Again, these enzymes are very, very important. That is, which enzymes are elevated in JDM? Creatine kinase, AST, LDH, allurase. Mind it is AST. EMG changes, electromyographic changes suggestive of fibrillation, etc. And muscle biopsy suggestive of inflammation and necrosis. Right? So, one question is juvenile dermatomyositis possible without dermatological features? The answer is yes. It's a separate entity or subtype of JDM which is known as amyotrophic juvenile dermatomyositis. But let me tell you, it is possible. So you need to get, normally you should remember, we need to have some dermatological manifestations, some myositis, together forms the juvenile dermatomyositis. For confirmation, we need the muscle biopsy and we also need the EMG, and this is the diagnostic criteria of JDM. We should remember the image of the Gottron's papules and the heliotrope rash and the antibodies anti-Jo1 antibody and anti-MDA5, which are associated with juvenile dermatomyositis. And what is the treatment that we suggest or treatment that is advocated for JDM? is steroids. Okay. Now, next, see this image. Again, this is a very repeated and a favorite question of NEETPG, INICET. So, it is a rash which is distributed in the buttocks and the lower limbs. So, this is nothing. If I'm going to zoom you so that you can see it very properly, that this is nothing but the palpable purpura. So, a disease where there is a palpable purpura distributed in the lower limbs and the buttocks, and you need to counsel the parents that this rash can recur in your child. And this is the most common involvement, that is, the skin is the most common organ involvement in this disease, and the most common manifestation of this disease is palpable purpura. Likewise, what I said previously, that if you do not get fever in Kawasaki disease, we cannot say that it is Kawasaki. Like that, the mandatory Euler criteria for this disease is a skin involvement and this rash. So this is a mandatory criteria. You may not have the other criterias, but involvement of skin and palpable purpura is a must, right? So we are dealing with a condition that is known as Henoch-Schönlein purpura. Henoch and Schönlein, teacher and student, found out a disease, that is Henoch-Schönlein purpura, and there is deposition of IgA. So what deposition occurs? IgA deposition occurs. If you do a renal biopsy, you're going to get IgA deposition, and if you're going to do a skin biopsy, then you are going to get a leukocytoclastic vasculitis. So remember, this is the most common vasculitis in the world and the second most common vasculitis in India. Skin biopsy करोगे तो leukocytoclastic vasculitis मिलेगी, and it is a type of small vessel vasculitis. Kawasaki क्या था? Medium vessel vasculitis था, right? So let us see the tetrad of Henoch-Schönlein purpura. Now remember, usually whenever the parents see this rash, they come to your clinic. ये rash निकाला है, निकल गया, क्या होगा? So they are very panicked. But you need to reassure. Don't need to get stressed because this is self-limiting. You just need conservative management. 90 to 95% cases has got an excellent prognosis. Only in less than 5% cases they go for end stage renal disease, right? So first is palpable purpura that you get in 90 to 100% cases. I told you skin involvement is the most important. Next, we get the colicky abdominal pain. So, melena, that is the blood in stool. So, always I tell my juniors during rounds that whenever you see a patient of Henoch-Schönlein purpura, every day in the rounds, you should ask that whether there is a pain abdomen, whether there is a blood in stool. Why? Because you need to think about it. There is a chance of rectal prolapse. There is a chance of intussusception. Okay. So second most common organ involvement after skin is GIT. So skin के बाद GIT involve होता है. Next is the arthritis or arthralgia. So we know the differences between arthritis and arthralgia. Arthralgia means pain in the joint, whereas arthritis, there is signs of inflammation in the joint. And the last is glomerulonephritis. Usually we get proteinuria with or without hematuria. That is known as HSP nephritis. So least common organ involvement in HSP is kidney. And usually kidney involvement is 3 months after the involvement of the skin. Whenever a patient comes to me, her patient ko skin biopsy, renal biopsy karna hai, the answer is no. Those patients which are presenting with HSP nephritis and they with a deranged creatinine level, then we are going to go for this renal biopsy. And skin biopsy is also not indicated. So the treatment is conservative and the prognosis is very, very good. Only less than 5% cases go for end stage renal disease. Otherwise, you just need to counsel that nothing to worry. And remember another thing, in case of Henoch-Schönlein purpura, when are steroids indicated? Steroids are indicated in two conditions. One is GIT vasculitis, GIT involvement. So whenever the child will complain of colicky abdominal pain, there is going to be melena, there is going to be intussusception, rectal prolapse, etc. So in GIT involvement, we give steroids, and also in case of renal involvement. So renal and GIT are the two organs where steroids are indicated in a child with henoch-Schönlein purpura. Majority of the cases are self-limiting, so you need to just tell the parents, counsel the parents. You do not need to worry about this. So आपको ये इमेज याद आएगा, तो ये इमेज देखकर इट्स अ palpable purpura. Most common organ involvement is skin followed by GIT. Excellent prognosis. Steroids only given in GIT and kidney involvement. Which immunoglobulin gets deposited in henoch-Schönlein purpura? The answer is IgA. What type of vasculitis you get in henoch-Schönlein purpura? Leukocytoclastic vasculitis. It's a small vessel vasculitis. Now, coming to GIA, juvenile idiopathic arthritis. So it's an arthritis in the juvenile period. How juvenile means what is the age cutoff? Age less than 16 years. So J of juvenile means age less than 16 years. And it is a chronic arthritis. That is arthritis of duration more than 6 weeks. Right? Can you see it? I'll just write it over here. So GIA means arthritis more than 6 weeks duration, exclusion of other diagnosis, that it is not IBD associated arthritis, age less than 16 years, joint involvement more than one, duration is more than 6 weeks. And if I am excluding other diagnosis means it is not other connective tissue disorder. So that tells me that I am dealing with juvenile idiopathic arthritis. So juvenile idiopathic arthritis has got various subtypes. It can be a psoriatic arthritis where there is psoriatic skin rash along with dactylitis, okay, and family history positive. Nail pitting, very characteristic of psoriatic type of GIA. There can be enthesitis related GIA. Enthesitis, the term came from itis of the enthesis. That is where the tendons get attached. It is HLA-B27 positive, associated with uveitis. Family history positive is there. Now next, it can be an oligoarticular, less than 4 joint involvement. Polyarticular, more than 5 joint involvement. Again, polyarticular GIA can be rheumatoid factor positive, rheumatoid factor negative. Usually in those patients where there is a RA factor positive GIA, usually we find the small joints of the hands are more involved, or the temporomandibular joint. The child will have difficulty in opening the mouth. There can be retrognathia. Rheumatoid nodules can be present. Small joints can be involved much more. And usually RA factor positive polyarthritis presents in the adolescence period, more than 5 years. Whereas in oligoarticular, again, it is of two types, persistent and extended. Persistent means less than 4 joint involvement initially था, वही रह गया, ठीक है? So the involvement of the joints never crossed more than 5. But if initially there were 3 or 4 joint involvement, but later on in the 6-month period, it increased to more number of joints, that is known as extended oligoarticular. You do not need to know so many things. At least remember, polyarticular means more than 5 joint involvement. There is one term called psoriatic arthritis where we have psoriaform rashes, dactylitis, nail pitting. There is enthesitis related arthritis where I told you there is a symptomatic uveitis, HLA-B27 positivity, and family history positive. And there is another thing which we are going to talk in detail, that is about the systemic onset GIA, because it comes in your question. And this is again, like I said, juvenile dermatomyositis is a personal favorite of INICET. GIA is also a personal favorite of INICET. So this systemic onset GIA is also known as the Still's disease. Remember, please do not confuse between Still's Marmor and Still's disease. Both of them are different. Okay. So systemic onset GIA we call SOGIA. तो सोजिया में क्या मिलेगी? तो आर्थराइटिस, इट इज अ सीवियर, usually large joint involvement, hip, temporomandibular cervical joint involvement is there. Fever, it is a quotidian fever more than 2 weeks. So it is more than 2 weeks. आपको GIA डायग्नोस करने के लिए 6 weeks लगता है, but systemic onset GIA diagnosis करने के लिए more than 2 weeks is enough. And what is meant by quotidian fever? Fever comes once daily. That is meant by quotidian fever. Double quotidian fever is found in another one-liner. Double quotidian fever. That is 2 spikes of fever in 24 hours. That is known as double quotidian fever. Double quotidian fever in entire medicine occurs in 2 places. One in GIA and number 2 in gonococcal infection. Remember this. One or more of the following: salmon pink evanescent rash in the trunks or proximal limbs, macular or maculopapular, organomegaly, generalized lymphadenopathy, and serositis. So organomegaly, by this I mean the hepatosplenomegaly, generalized lymphadenopathy, and serositis. Serositis means it can be a pleural effusion, pericardial effusion, or ascites. And what is meant by evanescent rash? That means it is non-fixed, transient. It is not going to last more than 24 hours. So if I get a child who is complaining of arthritis in the large joints with fever for 2 weeks, weight loss, and rash, there can be two differentials. It can be a case of juvenile idiopathic arthritis, or it can be a case of IBD associated arthritis. If it is a case of IBD associated arthritis, we'll have diarrhea. And we can also have some other manifestations. What manifestations? The rash is erythematous. It is known as erythema nodosum. So rash erythema nodosum is found in IBD. So IBD, what is IBD? Inflammatory bowel disease. So in inflammatory bowel disease associated arthritis, it is also a large joint involvement, but there also you get fever, there also you get weight loss, but it is associated with erythema nodosum. But if in that child you're getting hepatosplenomegaly, lymphadenopathy, serositis, pleural pericardial effusion, ascites, and the rash is evanescent salmon pink, maculopapular rash, yes, you are dealing with nothing but systemic onset GIA or the Steele's disease. Clear? Next, we come to the biologics that we use in rheumatology as well as in entire pediatrics. So first, we are going to do the TNF alpha inhibitors. Now, in this chart, please take a note where I have written about the anti-TNF antibody or anti-interleukin antibody, and where I have mentioned the word receptor. The places where I have used the word receptor, I have highlighted it. And this is very important because you might be reading this chart in your pharmacology class, but you must take a note where it is written receptor or where it is written antibody, because you might be getting confusing options in your paper. So let us start. Etanercept is TNF soluble receptor. Mind it is receptor. Adalimumab, satolizumab, golimumab, all these are anti-TNF antibody. Infliximab is anti-TNF antibody. Remember, usually anti-TNF antibody is given subcutaneously. However, infliximab is given intravenously. How can you remember? Infliximab has got an I, right? So it is given intravenous. Next comes abatacept. It is T cells co-stimulation inhibitor. T cell co-stimulation inhibitor. Anakinra is interleukin-1 receptor antagonist. Rilonacept is interleukin-1 soluble receptor antibody. And canakinumab, this is a new drug, mind it. It is anti-interleukin-1 antibody. Tocilizumab is anti-interleukin-6 receptor antibody. And all these are used in juvenile idiopathic arthritis, and there are other uses also, like in connective tissue disorders. You might be knowing in COVID, we used a lot of tocilizumab to prevent the cytokine storm. And rituximab has got various uses, like in Guillain-Barré syndrome, etc. And rituximab is a B cell depleter anti-CD20. Now coming to some drugs that we use in bronchial asthma. Mepolizumab, reslizumab is anti-interleukin 5. Benralizumab is anti-interleukin 5 receptor antibody, right? So why I'm saying that is anti-interleukin 5 receptor antibody? Remember, this is receptor, very important. You might get confused that whether it is anti-interleukin 5 or anti-interleukin 5 receptor. You how can you remember this? Ben Rally has gotten R, so it is against anti-interleukin 5 receptor. Dupilumab is anti-interleukin 4 receptor. Whereas lastly, we have the new drug in bronchial asthma, tezepelumab. This tezepelumab is anti-TSLP, thymic stromal lymphopoietin, thymic stromal lymphopoietin antibody. And you all know one drug which is very common, that is omalizumab. And omalizumab is against IgE. Okay, so this is the list of biologics that we use in pediatrics. One thing, please remember that while before starting any biologics, like mainly the anti-TNF alpha and the all that we use in GIA, usually it is a mandatory to do or rather rule out tuberculosis. Either you can do a CB-NAT or etc. Even a tuberculin skin test is also can also be done. So whenever in GIA, why do we go for TB testing? Number one, if you're getting a polyarthritis or a oligoarthritis, you might get confused that this can be a TB arthritis, right? Though TB arthritis is usually monoarticular, but there can be some chronic form as well, like the Ponson's disease, where it involves multiple joints. So you need to rule out tuberculosis for diagnosis, and also before starting any biologic agent. So before you start anti-TNF alpha, you need to rule out tuberculosis. Okay. Now, this is a very important chart which tells me the criteria of macrophage activation syndrome. Uh, for your exam purpose, you need not remember all the values, but you need to remember one clinical scenario, because as next is coming up, we are expecting, as I told earlier, more and more clinical oriented MCQs. So what question that we can expect? For example, in juvenile idiopathic arthritis, already I told you it is either an autoimmune process or an autoinflammatory process. So what happens here? All the inflammatory markers will be raised, like ESR, CRP, even the counts. So you will not expect cytopenia in a patient with GIA. Suppose a patient with GIA comes with acute attack, that there is increased pain in the joints, decreased range of motion in the joint. So you might be confused that whether this is a GIA flare or it is something else. What something else am I talking about? I'm talking about macrophage activation syndrome. In short, we call it as MAS, right? So we need to know whether we are dealing with a GIA flare or we are dealing with MAS. So what happens if it is a GIA flare? All the counts will be high. The CRP will be high, the ESR will be high, the total leukocyte count will be high. Whereas in macrophage activation syndrome, we are going to get cytopenias. Apart from cytopenias, we are also going to get hyperferritinemia. So there was one question in INICET 2021 where one option was there, serum ferritin is normal and counts are not raised in GIA flare up. The answer is wrong, because ferritin is raised in mass and the counts are low in mass, but in GIA flare, the counts will be high. So you need to remember this value, that ferritin is high, more than 684 nanogram per ml, and any two of the following. That is, platelet will go down less than 1.8 lakh, AST will go up more than 48. Remember, here also we have aspartate aminotransferase. We also talked about in JDM where we are having AST as the enzyme. Here also it is AST as the enzyme. Triglycerides more than 156 milligrams per dl, and fibrinogen less than equals to 360 milligrams per dl. You might not be remembering the absolute values, okay, But what you can remember is that we are going to get hyperferritinemia, elevated liver enzymes, hypertriglyceridemia, and hypofibrinogenemia. So even if you remember this thing grossly with the value of ferritin, which is more than 684 nanogram per ml, that is enough. Okay. And one more thing you can remember, usually in our institutions, sometimes it is not possible to do fibrinogen. So as a surrogate marker of fibrinogen, we always do the ESR. So if fibrinogen is low, the ESR is also low. So if I do an ESR and the ESR is low, we can predict that the fibrinogen will be low, right? So normally in GIA flare, the counts will be high, the CRP will be more, the ESR will be more. But in mass, what you can remember, there's going to be cytopenia, along with there is a decreased ESR. So have you understood this? So next, let's come to the guideline of hemophagocytic lymphohistiocytosis. So hemophagocytic lymphohistiocytosis. That is, it is a condition, it is a dreaded emergency which needs to be treated in intensive care. Type of HLH which we get in GIA, that only we call it as macrophage activation syndrome. So HLH is nothing but we get the hemophagocytes in bone marrow, spleen, lymph nodes, and liver. And it is a dreaded emergency. We need to give steroids, we need to give methotrexate, dexamethasone, etc. And we need to treat it in intensive care. Now, HLH can be familial or it can be acquired. So it can be primary, it can be secondary. Secondary HLH has got numerous causes. Like a dengue patient can also develop a secondary HLH, or any connective tissues in inborn error of metabolism. There can be a chance of HLH. So in fever of unknown origin, if the child is deteriorating, there is persistent fever with low counts, raised ferritin, along with jaundice, we need to think about HLH as one of the possible diagnoses. And it should be, you may lose the child. So you need to be very cautious, because the mortality and the morbidity of this condition is very high. Now, this is an extra age question. I am discussing this in view of next. Okay. So first is you are going to get, remember, there can be a genetic defect that is consistent with HLH. So we can have a genetic defect consistent with HLH, right? And we have this 8 criteria that you can see. Out of them, at least 5 should be positive. So 5 out of 8 clinical and laboratory criteria must be satisfied. So 5 out of 8 clinical and laboratory criteria must be satisfied. So again, as I told in the previous slide, that you may not remember the absolute values, but you need to remember that what changes occur in which parameter. So we'll have a persistent fever, we'll have splenomegaly, we'll have cytopenia in more than equal to 2 cell lineages, hemoglobin less than 9 in children, in neonates it's less than 10 grams per dl, platelet count less than 1 lakh, neutrophil count less than 1000, and triglycerides are going to be more than 265. Again, fibrinogen is low, less than 150. That means ESR is also going to be low. Hyperferritinemia, more than 500 nanograms per ml. So there in mass, the cutoff of ferritin was 684. However, in HLH, the cutoff of ferritin is 500. And what is the CD marker? It is CD25. Remember this, CD25. Soluble CD25 elevated more than 2400 units per ml. And hemophagocytes, you can get it in bone marrow, spleen, lymph nodes, or liver. And there is low or absent NK cell cytotoxicity. So what are the clinical findings that you can get in case of hemophagocytic lymphohistiocytosis? You are going to get fever, you are going to get splenomegaly, there can be pallor, there can be bleeding tendencies with recurrent infections. And if you do a bone marrow, you can find the hemophagocytes. What laboratory markers you're going to find? You're going to find cytopenia in all lineages. Triglycerides are going to be more. There is going to be low ESR, low fibrinogen. The ferritin is high. How much high? It is more than 500 nanograms per ml. What CD marker you're going to get? The CD marker that you're going to get is more than 2400 units per ml, and there is going to be low or absent NK cell cytotoxicity, right? Now, next we'll come to a very important staging. This is a very important topic as far as medicine is concerned and even pediatrics. That is the systemic lupus erythematosus, SLE. And we are going to read here about the stages of lupus nephritis. Okay. So we are going to read here the stages of lupus nephritis. So we have, as you can see here, that we have got 6 stages of lupus nephritis. So first is the class 1 lupus nephritis. It is minimal mesangial glomerulonephritis. You're not going to find anything in the light microscopy, but there can be mesangial deposits on electron microscopy. Class 2 is mesangioproliferative. That is, there is proliferation of the mesangial matrix can be there. Whereas class 3 is focal proliferative, right? And class 4 is diffuse proliferative. Class 5 is membranous nephritis, and 6 is glomerulosclerosis. So what are the one-liners you can expect? First is most common type of lupus nephritis. So most common type of lupus nephritis is class 4 lupus nephritis or diffuse proliferative nephritis. Okay. And if I ask you what is the most severe type of lupus nephritis, again it will be the same answer, that is diffuse proliferative nephritis. So it is the most common type, along with it is the most severe type. Understood? Class 5 is membranous nephritis. You should remember membranous nephritis is class 5, and membranous nephritis will present with subepithelial deposit. And usually in class 3 and class 4, usually it presents with lupus flare, where we have to treat with intravenous methylprednisolone. And the most advanced stage is class 6. Almost it presents with end stage renal disease, glomerulosclerosis. Okay. So this is the most advanced form. And usually what happens in SLE nephritis, we always do a renal biopsy. The child might present with proteinuria, the child can present with hematuria, and persistently low complement levels. Sometimes we have a confusion that whether we are dealing with post-streptococcal glomerulonephritis, PSGN, or lupus nephritis. Okay, so what we can do, usually we just monitor it. Usually in PSGN, the complement level normalizes at 8 weeks. Again, this is an MCQ. In PSGN, the complement level normalizes at 8 weeks. However, in lupus nephritis, it will be persistently low. And if it is persistently low beyond 12 weeks, then we perform a renal biopsy, right? And the cause might be SLE. So, 2 one-liners I already told, that in PSGN, complement level normalizes by 8 weeks. And if there is a persistently low complement beyond 12 weeks, then we go for renal biopsy. And in renal biopsy, we can have in SLE deposition of all the immunoglobulins IgA, IgG, C3, C4. And so this is known as full house effect. So what is full house effect? You might be reading this in your pathology class. So full house effect is found in SLE. It actually denotes the deposition of all the immunoglobulins and the complement levels. Have you understood? Now again, another very important slide on the patterns of anti-nuclear antibody. So anti-nuclear antibody and anti-nuclear antibody pattern, we usually do it by indirect immunofluorescence. So indirect immunofluorescence Usually in SLE, the diagnosis of SLE stands on ANA, and we do it by HEP2 cell line. So whenever you write ANA in bracket, you should write as HEP2 cell line. So first is peripheral or rim. You can find that only the rim is stained, right? This is found in SLE, anti-DNA antibodies. Whereas the homogeneous, that is homogeneous or uniformly stained, that you can get in anti-DNA, anti-histone, anti-nucleosome. So it can be SLE, mixed connective tissue disorders, and rheumatoid arthritis. But what you need to remember from homogeneous or diffuse pattern is it is anti-histone. Anti-histone means it is drug-induced SLE. And remember, anti-nucleosomal antibody you get, it is the earliest manifestation or earliest antibody to be positive in SLE. So what is the earliest antibody to be positive in SLE? It is anti-nucleosomal antibody. So this is the earliest antibody positive in SLE. Now coming to speckled, what you should remember in speckled is very non-specific. So you can get it in SLE, you can get in systemic sclerosis, uh, in other connective tissue disorders. So as you can see, it can be anti-Smith, anti-RNP, anti-Rho, anti-La, anti-Jo1, anti-MI2, anti-SCL70, so varied. And centromere is anti-centromere antibodies, usually we get in case of CREST syndrome. And nucleolar is anti-nucleolar, we can get in SLE and again in CREST syndrome. Okay, so you need to identify these images, that what is the rim pattern of ANA, what is the homogeneous pattern, speckle pattern, इसमें बड़ा बड़ा dot होगा, centromere small dots like dot like thing, and nucleolar. So you should remember all these images because it's a very important IBQ, and you should remember 2-3 things about them, like homogeneous in anti-histone antibody is drug induced SLE, peripheral pattern in SLE, speckled of all connective tissue diseases, centromeric form or anti-centromere in limited scleroderma. Okay, now we are going to read 2-3 things about some very important one-liners. First, we are going to see is the drug-induced lupus. So, drug-induced lupus, what are the drugs which causes lupus? There is a wide list of drugs which can cause systemic lupus erythematosus, but at least we need to remember some of them. Like we can remember the prokinemide, okay? Hydralazine, isoniazid, anti-tubercular drug. So these 3 drugs are the most repeated ones in your papers, which causes drug-induced lupus. Remember what happens in SLE. In some cases, we need to remember the epidemiology, that whether it is more common in males or more common in females. As you know, it is a rule that all autoimmune disorders or rheumatological disorders are more common in females. In SLE, the ratio of female is to male is 9:1. However, that means in females it is much common as compared to males. However, in drug-induced lupus, it is male equals to female. Number 2 that you need to remember, that drug-induced lupus is a more benign form of lupus. So usually renal involvement and neurological involvement are usually very rare. So renal and neurological involvement rare. So what you can get here is that the involvement is the liver involvement. Hepatitis is common. And you already know the antibody that is positive in drug-induced lupus is anti-histone antibody. And what is going to be the ANA pattern in case of drug-induced lupus? Already I discussed. It is the homogeneous or the diffuse form. So we have covered various one-liners related to drug-induced lupus. Next is SLE-induced heart blocks. So if the mother has SLE, what heart disease can the child get? The child can get congenital heart blocks. So there are two questions. Which antibodies can be positive? Remember, anti-Rho, anti-La. So anti-Rho, anti-La is the first question. Number two, if there is a maternal SLE, we should always do an ECG in the baby to look for congenital heart blocks. Third is, which drug can you give to the mother to prevent such conditions? That is, what is the fetal therapy that you can provide to the mother so that the child is not going to have congenital heart blocks? That means one of the most important causes of fetal bradycardia is again SLE. So that drug is nothing but dexamethasone. So you understood that which steroid is safe in pregnancy. The answer is dexamethasone. So of course, I think you remember that in antenatal steroids, which we give to the mother for lung maturity in case of preterm babies, is dexamethasone, betamethasone. Again, for congenital adrenal hyperplasia, we give a drug to the mother to prevent in vitro virilization. As soon as congenital adrenal hyperplasia, in a mother with a previous pregnancy of congenital adrenal hyperplasia is diagnosed, we start the mother on dexamethasone. And usually in the second trimester, we go for a chorionic villus sampling to see the karyotype. If it is a male, we stop the drug. But if it is a female, to prevent in vitro virilization, we continue the drug. And when you should start it as soon as possible. So the third indication I'm teaching you today is SLE induced heart block, where you give dexamethasone. So three one-liners related to this. Now, manifestation of Sjogren syndrome. I think you read in your medicine classes like Sjogren syndrome presents with dry eyes, xerostomia, xerophthalmia, and there is Sika syndrome. But usually in children, the dry eyes, dry mouth, all these are relatively uncommon. They can be present, but the most common manifestation of Sjogren syndrome in children is recurrent parotitis. So this one liner I would like you all to remember. That is the most common manifestation of Sjogren syndrome in case of children is recurrent parotitis, unlike adults where xerophthalmia, xerostomia are more common. Understood? So here we read about the drug-induced lupus, SLE-induced heart block, and the most common manifestation of Sjogren syndrome. Now, see this baby, and this image actually teaches you many things. First, look at the head of the baby. So I think you can appreciate the macrocephaly, right? There can be a bit of frontal bossing as well. Now look at the arms and the thighs. Can you see that the humerus and the femur is short as compared to the forearm and the legs? Okay, so this is nothing but this pattern that where the humerus and the femur is shorter as compared to the forearm and the legs. This is known as rhizomelic shortening of limbs. And of course, I think you can appreciate the short stature. Okay, and this short stature is disproportionate. Why I'm saying that this short stature is disproportionate, just see the ratio of the upper segment and the lower segment. So the upper segment and the lower segment, the upper segment is more as compared to the lower segment. So this condition is the most common genetic cause of disproportionate short stature. Every word is important. Most common genetic cause of disproportionate short stature. So it's a pathological short stature, disproportionate short stature, and genetic cause. So let me write the one liner for you. So it is the most common genetic cause of disproportionate short stature. Again, look at the hands. Here it is not much visible, but there is usually a gap between the third and the fourth finger and the first and the second finger, right? So this pattern of hand is known as trident hand. So what is it known as? Trident hand. Others, we can have some problem with the spine. There can be lumbar lordosis, etc. These children can have dental problems, sleep abnormalities, obstructive sleep apnea, etc. And apart from all these, which I told you, you should also remember two more things about them, that they have got normal IQ and normal lifespan. Usually, when these children grew up, you might find them in circus. Usually, the jokers, and of course, it doesn't mean that the jokers in the circus are mentally retarded. They usually have a normal IQ, normal cognition. So, these 2 points are very very important regarding this condition, that they are having a normal IQ and normal lifespan. Yes, you're right. We are dealing with a condition which is nothing but the most common skeletal dysplasia in children, that is nothing but achondroplasia. And it is a very very important topic for your NEETPG as well as INICET, and even for your coming Fmge examinations. So we are dealing with achondroplasia. Now look at this image. So this actually image, radiological image, there is flattening of the iliac bones, and the pelvis is shaped like a champagne glass. So let me draw the first view it. I'll draw the champagne glass for you. So this is the champagne glass pelvis. Two more MCQs mainly for your Fmge exams. First is, what is the inheritance pattern of achondroplasia? What is the Mendelian inheritance of achondroplasia? The answer is autosomal dominant. So this is autosomal dominant. Next question. So the mutation is FGFR3 mutation. It is the most common type of skeletal dysplasia in children. Again, second one liner, most common non-lethal skeletal dysplasia in children. So, most common skeletal dysplasia in children, and remember, it is non-lethal. So when I use the word non-lethal, that means there is one form of skeletal dysplasia where it is lethal. So what is the most common lethal skeletal dysplasia in children? You just need to remember the name. You might have read in radiology class, most common lethal skeletal dysplasia in children, where the femur is shaped like a telephone, right? Telephone shaped deformity of femur is found in that. The answer to that question is only the most common lethal dysplasia in children. The most common lethal skeletal dysplasia in children is thanatophoric dysplasia. So let us write down. So most common lethal skeletal dysplasia in children is thanatophoric dysplasia. So most common lethal skeletal dysplasia in children is thanatophoric dysplasia. So have you understood all the important MCQ points? I have covered almost all important MCQ points related to achondroplasia. And remember these two highlighting points, which I'm stressing, that they are having a normal IQ and normal lifespan. So normal IQ, normal lifespan is achondroplasia. Remember this image, you will understand it. There are few points which I have highlighted from primary immunodeficiency. You might be reading it in your pathology, but I would just like to just say one, two, or three key features from every primary immunodeficiency. So first is we are going to read about the Chidiac-Higashi syndrome. Chidiac-Higashi syndrome. So what is the gene involved in Chidiac-Higashi syndrome? The gene involved in Chidiac-Higashi syndrome is the List gene. So List gene is involved in Chidiac-Higashi syndrome. And in Chidiac-Higashi syndrome, we are going to have oculocutaneous albinism, and vitamin C is used in the treatment. So remember an overload of C. Chidiac-Higashi, oculocutaneous albinism, and vitamin C used as therapy. Now, the second one is chronic granulomatous disease. As the name suggests, granulomatous disease. That means there is granuloma formation. Why there is granuloma formation? Because there is a deficiency of NADPH oxidase system. So, deficiency of NADPH oxidase system, which results in granuloma formation, and you're going to get recurrent infection due to catalyst positive organisms. So catalyst positive organisms, recurrent infection, and it is X-linked recessive. And as you know as a dictum, X-linked recessive disorders are more common in males. Coming to GATA2 deficiency. In GATA2 deficiency, we'll have atypical mycobacterial infections. Costman syndrome. ANC, that is absolute neutrophil count, is less than 100. Usually in your question, you might not be asked what is the absolute neutrophil count in Costman syndrome. You can be asked that neutropenia is found in Costman syndrome as a one-liner, true or false. So neutropenia found in Costman syndrome is a true, and the neutropenia is profound neutropenia because the absolute neutrophil count is less than 100. Most common type in SCN, okay, that is elastase 2 gene. So elastase 2 gene. Next is LAD. LAD is leukocyte adhesion deficiency. Leukocyte adhesion deficiency type 2. What happens, in newborn, when there is a delayed fall of the umbilical cord, we can think about, and there is a bleeding manifestations, we can think about leukocyte adhesion deficiency. And leukocyte adhesion deficiency is of three types. It's not a mandatory to know all the three types, but usually they are integrin, selectin, all these are defectives. So in leukocyte adhesion deficiency type 2, they are more common in those individuals with Bombay blood group. Remember AB, B is the second letter what, and LAD type 2. This is how you can remember. This is a very, very important question. That is leukocyte adhesion deficiency type 2 is found in Bombay blood group. Whereas LAD type 3 can present with bleeding disorders that can mimic Glanzmann thrombasthenia. So LAD type 3 presents with bleeding disorder that mimics Glanzmann thrombasthenia. Now, most common complement protein deficiency, again it is a repeated question, is deficiency of C2. You might be reading this in microbiology class as well. So the most common complement protein deficiency is deficiency of C2. And another important is C5 to C9, or the late complement deficiency, is more common in Neisseria infections. So meningococci affects the late complements. Okay. So hope this chart is clear regarding the Chidiac-Higashi, chronic granulomatous disease, GATA2 deficiency, Costman syndrome, and LAD type 2 and 3. And the most common complement protein deficiency is deficiency of C2 complement protein. Now, coming to C1 inhibitor deficiency. So C1 inhibitor deficiency is autosomal dominant condition. So C1 inhibitor deficiency is autosomal dominant condition. Now, what are the drugs that are used for C1 inhibitor deficiency? Now, these drugs are again very, very important. Why? Because again, these are new drugs also, and they are very important from your pharmacology point of view as well. First is ecallantide. It is a kallikrein inhibitor. Next is icatibant. Icatibant has been asked previously in NEETPG. B2 receptor antagonist. That is, what is B2? It is not beta 2. It is B2, bradykinin receptor antagonist. And lanadelumab. Lanadelumab is anti-kallikrein monoclonal antibody. So either you are having a antibody against the bradykinin receptor, that is icatibant, or you're having anti-kallikrein monoclonal antibody, that is lanadelumab, or if you're having a kallikrein inhibitor, is ecallantide. So a better name which you all are associated regarding C1 inhibitor deficiency is hereditary angioedema. Okay, so another name is hereditary angioedema. C1 inhibitor deficiency. And as I told you that this hereditary angioedema or C1 inhibitor deficiency is an autosomal dominant condition. And so what happens here is that there is we need to inhibit the kallikrein, okay, and the bradykinin. And there is angioedema. Next, coming to chronic mucocutaneous candidiasis. As the name suggests, candidiasis. So there is recurrent candida infections. So which disorder presents with recurrent fungal infection? The answer will be mucocutaneous candidiasis. Already I read one thing, that is the recurrent catalyst positive organisms. Infection by recurrent catalyst positive organisms. The answer was chronic granulomatous disease. Recurrent fungal infection is CMC. Now, giardiasis, diarrhea by giardiasis is more common in CVID. What is CVID? Common variable immunodeficiency. Selective IgA deficiency is associated with celiac disease. Now, celiac disease, it's a condition where there is a problem with the gluten and the gene. Usually what happens, there is destruction of the mucosal membrane, and because those people are sustained, they are having some insensitivity to gluten means you get in wheat, barley, rye, oats, etc. Barley, rye, oats, wheat, all these things are having gluten. So these people who are more on this diet, that is the brow diet, we say barley, rye, oat, and wheat. So they are having a permanent gluten sensitivity, and they are genetically predisposed also, HLA predisposed. So they develop celiac disease, and celiac disease has got numerous extra intestinal manifestations. One of them, so which primary immunodeficiency is most commonly associated with celiac disease? The answer will be selective IgA deficiency. Again, this is a repeat question. In Ames paper, you actually got the flow cytometry image regarding this hyper IgM syndrome. Remember, the ligand CD40 ligand is involved. So CD40 ligand mutation found in hyper IgM syndrome. And X-linked SCID. What is SCID? Severe combined immunodeficiency. Okay, so the history was about the bubble baby disease and X-linked SCID. SCID can be X-linked, it can be autosomal as well. So X-linked SCID is associated with interleukin 2 RG. Ataxia telangiectasia, we'll read it that there are two manifestations. One is ataxia, that is the cerebellar signs are going to be positive along with dysarthria, gait abnormalities, etc. And there is going to be telangiectatic vessels in the bulbar conjunctiva. It is associated with ATM gene on chromosome 11q. And since I told you that is the cerebellum is affected, so which specifically cell is affected? The Purkinje cells of the cerebellum is involved. Okay, so a primary immunodeficiency, if I frame a clinical question, a child presents with ataxia and all the cerebellar signs are positive, the Rombach sign is positive, and on examination you find telangiectatic vessels in the bulbar conjunctiva. What is your diagnosis? The answer is ataxia telangiectasia. Which gene is involved? ATM gene is involved. Which chromosome is involved? 11q is involved. Which cells are affected? Purkinje cells are affected. Complete list of all the one-liners that can be asked from ATM, that is ataxia telangiectasia. In hyper IgE syndrome, we first talked about hyper IgM syndrome, which is a problem with the mutation in the CD40 ligand. Now next we are dealing with the hyper IgE syndrome, right? Hyper IgE syndrome is also known as Job syndrome. So here you are going to get recurrent pneumatoceles. Recurrent pneumatoceles. Now one more question. Can you tell me the most common cause of pneumatocele? The answer will be Staphylococcal aureus. So Staphylococcus aureus. So the most common cause of pneumatocele is Staphylococcus aureus, and pneumatoceles are found in hyper IgE syndrome. Okay, so summarizing, recurrent candida infection in mucocutaneous candidiasis, whereas recurrent catalase positive infection in chronic granulomatous disease, giardia infection and diarrhea due to giardia is common variable immunodeficiency, whereas pneumatoceles in hyper IgE syndrome. Primary immunodeficiency where cerebellum is affected is ataxia telangiectasia. In celiac disease, most common primary immunodeficiency is hyper IgM syndrome, and Bombay blood group is associated with leukocyte adhesion disease type 2. Okay, and atypical mycobacterial infections you're going to get in GATA2 deficiency, and at least you should know all the drugs related to hereditary angioedema. So this is a very short table which summarizes all the primary immunodeficiencies that we encountered. Okay, so in my pediatrics marathon series part 1, we have finished the rheumatology. Please wait for the second section where we are going to discuss the most important points from cardiology. Thank you. All the best for your exams.